The learning objectives for today's session, which I'll be discussing, are: explain the mechanism of anaphylaxis, hay fever, atopic dermatitis, allergy march, and non-atopic reactions; describe the changes that take place in IgE-coated mast cells on binding with a specific antigen; discuss the different diagnostic tests and immunotherapy based on type 1 and type 4 hypersensitivity, and the 3 different variants of type 4 hypersensitivity with their presentation. So normally you all might have heard about different allergies. People are allergens to pollens, dust mites, animal danders, and what they have is the symptoms. The patient tend to have watery eyes, runny nose or itchy throat. Sometimes they have redness of the eye, conjunctivitis, or sneezing, and some patients tend to have bronchial asthma as well. So that's the extreme end of the allergy. Along with bee stings can result in anaphylaxis caused by bee venom. And children tend to have atopic dermatitis, which is redness and of the skin around face, elbows, and knees. And finally, there is a condition called contact dermatitis that is caused by poison ivy. All these conditions are actually the result of hypersensitivity. So what is hypersensitivity? Normally an immune response has to be in a balanced state. If it goes over-exaggerated, so it's working more than it is needed, that is going to cause harm, that is going to cause hypersensitivity. Or if it is going to work less, inadequate, so the regulatory cells of the immune system, they are not working. In both the cases, the immune system is not balanced, and as a result, you will have hypersensitivity. Now, hypersensitivity has been classified by Coombs and Gell. They were 2 physicians. They have classified hypersensitivity into 4 different types. Okay, type 1 is mediated by IgE antibody. So the first 3 types, they are mediated by antibodies, while the last type, the 4th type, it is mediated by cells. So it's a cell-mediated hypersensitivity. In first type, here you can see there is an allergen, it is bound to the antibody, and it results in degranulation of mast cells. So it's actually IgE mediated hypersensitivity. So that's the key here, that it's IgE mediated, it will result in mast cell degranulation. And what is inside the mast cell? Histamine, heparin, prostaglandins, and cytokines. We'll see all the details in a moment. Now look at type 2 hypersensitivity. This one is mediated by IgG and IgM. I have put 2 examples of both of them. So for example, in type 1, in type 2, you can see here IgG antibody coats the target cell, and for just an example, it can be red blood cells from some donor. So when they are coated by IgG, it will act as a activator of natural killer cell. So if you remember ADCC, antibody dependent cell mediated cytotoxicity, they will kill these red blood cells. On another hand, IgM antibody below this, he has the capability of activating complement system, the classical pathway. So the complement protein can kill or target the cell. Both the cases, there is cytotoxicity caused by immunoglobulins, IgG and IgM. So type 1 mediated by IgE, type 2 mediated by IgG and IgM. Type 3 can be any antibodies which are in excess. So normally antibodies will be produced against the pathogens. If they are in excess in the bloodstream, what they will do, they will create immune complexes with the antigens. They will bind randomly different antigens, and when antibody binds to an antigen, it becomes immune complex, and these immune complexes can precipitate. They can deposit in the kidney, they can deposit in the joints, and lead to autoimmune diseases. One of the examples is SLE, systemic lupus erythematosus. Coming to the 4th type, type 4, it is mediated by T cells, in particular Th1. So in this you can see the antigen has bound to activated the T cell. T cell will then in turn produce interferon gamma, and that interferon gamma will activate the macrophages, and then the damage will be caused by the macrophages. So these are the 4 different types of hypersensitivity. Today we are going to discuss type 1 and type 4, and for some obvious reasons. Type 1 is called as immediate hypersensitivity, type 4 is called as delayed hypersensitivity, and that depends on the time that they take. Immediate will be immediate, 5 to 20 minutes there is a reaction. Delayed hypersensitivity takes around 48 to 72 hours. That's why it is called as delayed hypersensitivity. And if you look at the title of our lecture today, it's immediate and delayed hypersensitivity. Then tomorrow I'll be discussing type 2 and type 3. So what are the features of immediate hypersensitivity or type 1 mediated hypersensitivity? It's rapid, as I said, it will take 5 to 20 minutes on repeated exposure or subsequent exposure. So first exposure, nothing happens. Keep in mind, anyone allergic to peanuts, to milk, to any any proteins, they will not have allergy the first time. The first time there is sensitization process, we'll see that, and then on subsequent exposure there is a rapid response. Patient tend to have itching, they will have bronchospasm, they will have swelling, redness. All these features are of subsequent exposure. And what type of allergens can cause this? That can be proteins or chemicals like pollens, house dust mites, animal dander, food, and even sometimes antibiotics like penicillin, very well known for causing allergy, type 1 hypersensitivity. Now the events in immediate hypersensitivity are shown here, but we'll start with, step by step. There are certain things which are not mentioned here, so I'll start here. So let's see if there is a sting or a bee venom that has been inserted into the skin. It will be first taken up by dendritic cells. Which receptors will take it? PRR will take it up, and then this dendritic cell is going to move towards where? Lymph nodes. So this is going to go into the lymph nodes. At the same time, here the T cells are going to come here in the lymph node, and the dendritic cell is going to present the antigen here with the help of which receptors? MHC class 2 to CD4. Now, as a result of this activation, you need co-stimulatory signals, cytokines will be produced, and this T cell is activated. Now, the B cells here in the circulation, they go to the tissue, they also can bind to the antigen with the help of what? B cell receptor. They take it up. They also make their way to this, and here are certain things which are called as germinal centers. In the germinal center, this activated T cell is going to interact with B cell. If this T cell produces IL-4, what's going to happen? Yes. So basically, the allergens tend to create Th2 response. Okay. This Th2 will give help to B cell, and IL-4 and IL-5 will be produced. So B cells should produce which antibodies? IgE. There will be class switching. Plasma cells that are produced, they will produce IgE, which is specific of Th2 in allergy and parasitic infection. Then these large number of B cells, they are going to go back towards the tissue. And now when the allergen is here in the tissue, when they will bind to the B cell, they are already capable of producing IgE antibodies. So lot of IgE antibodies will be produced. Then the antibodies that are produced, we have in tissue some special cells, they are called as mast cells. Now mast cells have got special receptor for IgE antibodies. These are termed as Fc epsilon R1. It's very simple. You can see here that the immunoglobulin that is bind here, it has got Fc portion. This is the Fc portion. This immunoglobulin is IgE. So Fc is for this Fc portion, E is for immunoglobulin E, R is for receptor. So does it make sense that you have got first the antigen came in, dendritic cell took it to the lymph node, polarized Th2 cells. Th2 cells produce IL-4. B cell captured the antigen. It came to the germinal center. Here there was somatic hypermutation, class switching. As a result, IgE antibody producing plasma cells, B cells are produced. They will move back to the tissue. Here they will start producing a lot of IgE. So a lot of IgE is produced. This then tissues have mast cells. So like macrophages, tissues have mast cells as well. They don't circulate. In circulations are basophil, in tissues are mast cell. They are same in function. Like monocytes, they are in blood, and macrophages are in tissues. So mast cells have got some receptors. These receptors are called FCER1. Fc is for Fc portion, E for IgE, and receptor is R. So all the mast cell is now coated with IgE antibody. This is called as sensitization. This is the first exposure. You remember I told you, anyone allergic to anything, they will not have any response the first time. Why? Because this has to take place. It normally can take 2 days, 5 days, 10 days, and then after the memory cells are formed, after the sensitization has taken place, second exposure, you will have immediate response. So this thing is called as sensitization. On first exposure. Now let's say the second exposure has occurred. What will happen? The allergen has come in. It will directly bind to these antibodies. Cross-linking. These two immunoglobulins, they bind to the allergen. What will happen? This time mast cells is going to directly release the mediators. So mediators are released. And they will cause the symptoms of allergy. All of you understand this part? Yes, please.
What is the role of B cells in the
sensitization? So imagine if B cells have not produced IgE and IgE has not gone there and not bound to the mast cells, there won't be any response. IgE is the very important key. If IgE is produced, it goes here, it binds to the mast cell, only then mast cell will recognize the allergen. If IgE is not produced, even if allergen is there, it will not cause degranulation of the mast cells. So the presence of IgE is very important to bind to the mast cells, and then it will cause degranulation. Yes, please.
What will happen after Th2 is polarized?
So when Th2 is polarized, now this Th2 is ready to help B cell to produce IgE to cause class switching. Okay, so if Th2 is not there, IL-4 will not be produced, IL-5 will not be produced, and B cells will not start producing IgE. It will keep producing IgM and IgG, which is not helpful for allergy. It will not cause allergy. Now if you see in this figure, here we have started directly with the allergen coming here, and it is binding to the B cell, and as a result what's happening, they have directly shown that IgE secreting plasma cells are there, mast cells have got Fc epsilon R1. So the first exposure has resulted in sensitization. After sensitization, what happens? Two groups of mediators are produced. One are histamine, bradykinin, immediate chemical mediators. Another group is late mediators. They will result in production of prostaglandins and cytokines. So after 20 minutes, histamine will be released, but late mediators will take around 6 to 24 hours. Now, there are two terms, atopic and non-atopic. When we say atopic dermatitis, that means definitely the whole mechanism is this. You need to have sensitization, production of IgE, sensitization of mast cells, and degranulation. That is must. So anybody who has got atopic dermatitis, who has got atopic asthma, so asthma, they have different types. The atopic type will have this phenomena. But then there is another group that is called as non-atopic. Non-atopic groups, mast cells can degranulate without the need of IgE antibodies, without sensitization. And what can cause? There are just couple of examples. One is exercise. Some people, they get asthma attacks when they go for exercise. Some people, when they are exposed to cold air, they will have asthma attack. Then there are people, have you heard that people can do, their contrast media is injected to do the intravenous pyelograms. If somebody has stone, you can do x-rays that can find out the opacity in the ureter or urinary bladder. So they are injected with dyes. These dyes can go in these, urinary tract, and then you can find out if there is an opacity. So when you inject these dyes, some people are allergic to those. So they will have the reaction, but that is not atopic, it's non-atopic. So the examples of non-atopic allergies are cold air, exercise, contrast media or dyes, and finally an antibiotic called as vancomycin. So the allergy caused by penicillin is this type. The allergy caused by vancomycin is non-atopic. So do you all understand the difference between atopic and non-atopic? No. So everything that you see here, Th2 polarization, B cells coming to it, IgE class switching, this will result in IgE production and coating of mast cells. Do you all appreciate these steps one by one? So once this whole thing has occurred and mast cells have been coated, and when they release mediators like mast cells and histamine, this whole process is called as atopic. Okay, so now whether somebody has asthma or they have got allergy to penicillin, they have allergy to pollens, that will follow this phenomena or this mechanism. This group is termed as atopic allergy. Okay, then there are few examples where this full phenomena is not needed. Mast cells without IgE, without Th2, without B cells, they will directly degranulate. But the signal is, if cold air comes in the lungs, the mast cells will degranulate. If the patient exercises, now there is genetic reason, certain genes are there, because of that the mast cells will immediately degranulate. Or if you give them medicine, vancomycin, the mast cells will degranulate without the use of IgE, without the Th2, without the B cells. This group is termed as non-atopic. So we have two groups. Atopic need to have what? They need to have Th2, B cells, IgE, and then coating of mast cells. While non-atopic, no need of Th2, no need of IgE, No need of mast cells around that, just simple triggering factors. What are these triggering factors? Exercise, yes. Cold air, vancomycin, and dyes. Sometimes you know that dyes that are given by the radiologist to carry out some x-rays. So these are some of the examples that will result in direct, but majority atopic allergies are following this full phenomena. So now non-atopic reactions does not require IgE coating of mast cells, and example is they are more relying on the complement proteins C3a and C5a. As a result, whether it is atopic or non-atopic, what will happen? Preformed, mediators will be released like histamine, tryptase, and then on the other hand, after 6 hours, the prostaglandins and leukotrienes, and they will cause all the symptoms. Now, what are those symptoms? We'll see them. First thing, they can cause vasodilatation. We already talked about it. When the blood vessels dilate in the periphery, so what will happen to your blood pressure? It will drop because of the peripheral pooling. If there is bronchoconstriction, what will happen? Difficulty in breathing. So now I am talking about these effects can be local. So when there is a sting bite, that can initially have local effects, and later on if it spreads, it can have systemic effects. While in case of asthma, the patient inhales directly, the antigen or allergen is going to his lungs. There it is triggering the vascular dilatation or bronchoconstriction. That's why asthma patients have immediate bronchoconstriction. But these mediators, histamine, tryptase, prostaglandins, leukotrienes, they are all involved. And what else they can do? So when there is bronchodilation, they will also increase the blood supply to whichever area they are. When the capillary permeability increases, what will happen? It will result in swelling. So if you see in this patient, the eye is swollen. The reason is because of bronchodilation and increased permeability. The bronchial asthma, because of bronchoconstriction, the patient cannot breathe properly. Now these are some of the things. Yes, please.
How C3a and C5a are an example for
atopic. So you remember when we were discussing complement system, we said that normally each complement protein is divided into A and B. B's are mainly going in the complement cascade, classical, alternate, and mannose binding, while certain A's are produced, C3A, C4A, C5A, and there was a special name for them, anaphylatoxins. What was that? Vasodilatation, bronchoconstriction, and increased permeability, calling more immune cells. So sometimes when these cold air, vancomycin, dyes, or drugs, they can directly trigger complement C5 into C5A, and this will help in direct response or symptoms. Now sometime when the patient have allergy to food, they have abdominal cramps. Why? Because the intestine motility is increased. It's very speed up, and also they can result in inflammation and tissue damage. Now I'll just take you back. Recall that IgE can cause allergy, and IgE is also helpful against which infections? Parasites. Parasites are very big. Macrophages and dendritic cells cannot engulf them all. So for killing them, eosinophils are very effective. How they do it? They can come close to the parasite. Lot of eosinophils will cover the parasite, and then they will release their mediators like major basic proteins and peroxidases, and this will cause killing of the parasite directly. So during all this process, we are talking about IgE and mast cells effects in allergy, and this is just a small portion to just remind you that eosinophils and Th2 cells, they can also help in killing of the parasites. Now there is a phenomena that is termed as allergy march. What is allergy march? When children are small, they sometimes tend to have food allergies. Now this sequence, if you see here, after food allergies, eczema or atopic dermatitis, then hay fever or rhinitis and sneezing and runny nose, and finally asthma. Just remember that when you will come across patients who are little and they started to have food allergies, there is a possibility that they will develop all these one by one or any one of them in future. So the food allergy can, later on patient can have hay fever, or he may develop into a asthma patient. And here is the graph that is showing that with growing age, initially they have, if you see, they have just skin, eczema more, and GIT, blue line. But later on they can develop asthma and rhinitis with the growing age. So this is called as an allergy march, a possibility that sometimes patient as food allergy patients can develop these other conditions as well. Now this table, it is basically focusing on the causes. So for example, allergic rhinitis, which is also called as hay fever, that is caused by dust, cats, dog, mite, dander, and how it looks, the patient have edema, irritation of the nasal passage. Systemic anaphylaxis, so a venom is injected by a bee, it will result in bronchial or tracheal constriction. What I am here focusing on, asthma will be discussed in the coming lectures, but wheal and flare, in vivo skin testing for allergies. This is something very important because a lot of times people confuse the skin test which is done for type 1 with delayed type hypersensitivity reactions. So we'll see what are the differences. But before that, there's a scenario for you. A 62-year-old lady was stung by a bee while harvesting honey. She was stung several times before as well. So, is it the first exposure? This time she complained of itching of hands, feet and groin with abdominal cramps. Shortly afterwards, she felt faint and acutely short of breath. Now, itching. Which mediator is mainly responsible for itching? Histamine. So itching is a typical feature of histamine, reaction. Then she felt faint and acutely short of breath. These two symptoms are result of what? Bronchodilation and vasodilatation and bronchoconstriction. Her husband noticed rapid and wheezy breathing with swollen eyelid and lips. Her doctor husband administered epinephrine intramuscular and chlorpheniramine intravenous. Why? What could be the possible reason? So what is epinephrine? You all know? Yeah. What it can do? So they will actually reverse the effects. Airway will be dilated while the vascular constriction. So prevent hypovolemia and easy breathing. And what is chlorpheniramine? Anti-allergy. Okay, antihistamine. So intravascular, it is given so that it immediately blocks the histamine that has been released by the mast cells. Now, what mechanisms are involved in anaphylaxis? We have already seen that. It's mainly bronchoconstriction and vasodilatation because of histamine and prostaglandin. What are the clinical features and management of acute anaphylaxis? That also we know. How may such sensitivities be detected and what can be done to desensitize the patient? This is the part I'll discuss now. So here you can see 4 different reactions. The first one on top, it is this, and the second immediate plus late. They both are related with type 1 hypersensitivity. The third one, delayed, it is related with type 4. Okay. So So when you inject, what you will do, you will ask the patient come, and then you will inject subcutaneously allergen into the patient. Normally you can do pricking, that's why it is called a skin prick test as well. So you have a tray, it has got, let's say, 20 allergens, and you ask the patient to expose the forearm, and then A allergen, B allergen, C allergen, you just prick them all. Okay, then you ask the patient to sit down, and after just 1 hour you read the skin. Okay, you see what happened to which